For my patients that don't have a targetable mutation, I am using immunotherapy either alone or in combination with chemotherapy. One of the factors that I use to make this decision is PD-L1 testing as well as PD-L1 score. For my patients that have a very high PD-L1 level and don't really have a lot of symptoms, I do prefer to use pembrolizumab monotherapy. And recently we heard of the FDA's decision to approve Q6 week based dosing for pembrolizumab, which was welcomed, especially in the COVID-19 era when we were trying to minimize exposure to patients as well as limiting the number of times they had to come in. So I've certainly adopted that strategy for some of my patients that are undergoing pembrolizumab monotherapy. For other patients, that is, patients that have PD-L1 less than 50% or patients that have a very high symptom burden, my preference is to use a triplet regimen, either the Keynote 189 or the Keynote 407 approach. I will say that at this year's ASCO, we heard about two more combination therapy trials. We heard the 3-year update on Checkmate 227, as well as the Checkmate 9LA data, which showed us that using quadruplet therapy, using platinum doublet chemotherapy with nivolumab and ipilimumab, but using a shorter duration of chemotherapy could improve survival against chemotherapy alone. Now, both these regimens, that is Nivo-Ipi or this quadruplet approach with Checkmate 9LA, are both approved for the treatment of non-squamous non-small cell lung cancer and should be considered alternative options, although I have not used them quite aggressively just yet.